September 3, 1943. Normandy Beach, France. Lieutenant Robert Chen pressed his back against the blood-soaked sand as machine gun fire raked the shoreline above him. Shrapnel from a German grenade had torn through his left thigh, and infection was already setting in. In his medical kit lay a small vial containing a yellowish powder that would have been thrown away as contaminated waste just 15 years earlier. This powder, derived from what his professors once called a worthless mold, would save his life and the lives of millions more before the war ended. The substance was penicillin, and its journey from laboratory accident to battlefield miracle represents one of the most extraordinary reversals of scientific fortune in human history. The man who discovered it had been ridiculed by colleagues for his sloppy laboratory practices. His contaminated Petri dishes were considered embarrassing evidence of poor technique. Yet this same carelessness would unlock a weapon more powerful than any tank, bomber, or battleship in determining the outcome of World War II. But the story of how a Scottish bacteriologist's messy habits revolutionized medicine and changed the course of human history doesn't begin with breakthrough discoveries. It begins with death, devastating loss, and a medical profession that could do nothing but watch as infection claimed more lives than bullets, bombs, and poison gas combined. To understand why Alexander Fleming's accidental discovery represented such a monumental shift, you must first understand what medicine looked like before antibiotics existed, and why infection was the invisible enemy that terrified every surgeon, every soldier, and every parent more than any visible threat on any battlefield. In 1918, when Alexander Fleming returned from World War I, infection killed more soldiers than combat wounds. A simple cut could mean death within days. Pneumonia claimed victims faster than machine guns. Tuberculosis consumed entire families while doctors stood helpless. Surgery was a desperate gamble, where success depended more on luck than skill. Even minor operations carried mortality rates that would horrify modern physicians. Fleming had witnessed this helplessness firsthand as a captain in the Royal Army Medical Corps during the Great War. He watched strong young men survive artillery barrages and poison gas attacks only to die from infected scratches. He saw field hospitals where amputation was often the only defense against gangrene. He performed surgery knowing that opening a patient's body might save their life, or doom them to sepsis. The medical profession understood that microscopic organisms caused infection, but possessed no weapons to fight them. Doctors could clean wounds, amputate limbs, and pray. Antiseptics like carbolic acid could sterilize surfaces, but were too toxic for internal use. The human body remained defenseless against bacterial invasion. Fleming returned from France determined to find answers that had eluded medicine for centuries. Alexander Fleming was born August 6, 1881, on a farm in Lochfield, Scotland. Growing up in the rugged Scottish countryside, he developed exceptional observational skills, studying the natural world around him. His father's death when Alexander was 7 left the family struggling with economic hardship. At 13, Fleming moved to London for education, excelling in mathematics and natural sciences while working to support himself. After 4 years as a shipping clerk, he inherited a small sum from an uncle's estate in 1901. Rather than pursuing business, he made a decision that would change medical history by enrolling in medical school at St. Mary's Hospital. Fleming had witnessed too much suffering to pursue comfort. His brother John had died from pneumonia despite the best medical care available. His sister had lost 2 children to infectious diseases that doctors could neither prevent nor cure. Fleming entered medical school determined to understand the microscopic world that claimed so many lives. St. Mary's Hospital Medical School in 1901 was a world away from modern medical education. Students learned anatomy by dissecting cadavers in unheated rooms. They studied bacteriology with primitive microscopes and basic staining techniques. Laboratory work meant preparing their own culture media and sterilizing their own equipment. Fleming thrived in this hands-on environment. His professors noted that Fleming possessed an unusual combination of traits for a medical student. He was intensely curious about bacterial behavior, but seemed almost careless about laboratory cleanliness. While other students meticulously cleaned their work areas and carefully sealed culture dishes, Fleming often left experiments running longer than recommended, and sometimes forgot to properly close containers. Professor Almroth Wright, who directed the hospital's pathology department, initially considered Fleming's laboratory habits problematic. Wright had spent decades establishing rigorous protocols for bacterial research. Fleming's casual approach to laboratory hygiene seemed to confirm everything Wright taught students to avoid. Yet Wright also recognized that Fleming possessed exceptional observational skills and an intuitive understanding of bacterial behavior. After graduating in 1906, Fleming joined Wright's research team. During World War I, Fleming served as a captain in the Royal Army Medical Corps in France. The experience transformed his understanding of medicine's limitations. He treated thousands of wounded soldiers and watched infection claim victims who had survived horrific battlefield injuries. Gas gangrene, sepsis, and pneumonia killed soldiers faster than German artillery. Fleming worked in casualty clearing stations just behind the front lines, where speed meant everything. The wounded arrived in constant streams from the trenches, carried on stretchers by exhausted bearers who had crawled through mud and barbed wire under machine gun fire. Surgeons operated continuously, removing shrapnel, setting bones, and amputating limbs destroyed by high-explosive shells. The operating theaters were crude affairs, often little more than reinforced dugouts with surgical tables, improvised from wooden boards. Electric lighting was unreliable, forcing surgeons to work by oil lamps and candles. Sterilization was primitive at best. Instruments were cleaned in boiling water when fuel was available, sometimes merely wiped clean when it was not. But even successful operations often failed when infections set in days later. Fleming watched strong young men recover from surgery only to develop fevers that no treatment could break. Gangrene crept up from wounds that had seemed to be healing. Pneumonia claimed soldiers who had survived direct hits from artillery shells. The medical corps could repair traumatic injuries, but remained helpless against microscopic invaders. The most devastating cases involved gas gangrene, a rapidly spreading infection that destroyed muscle tissue faster than surgeons could amputate. Fleming saw entire wards filled with young men whose minor wounds had become death sentences. The smell of necrotic tissue became as familiar as the sound of distant artillery. Morphine could ease pain but could not stop the inexorable advance of bacterial infection. The experience convinced Fleming that medicine's greatest need was not better surgical techniques or improved trauma care, but weapons to fight microscopic enemies. Bacteria killed more efficiently than bullets because the human body had no defense against them. Fleming returned to London in 1919 obsessed with finding ways to help the immune system win battles it was losing. Back at St. Mary's Hospital, Fleming resumed research with Professor Wright's team. Their work focused on lysozyme, an enzyme found in tears, saliva, and mucus that could destroy certain bacteria. Fleming had discovered lysozyme in 1922 when he accidentally contaminated a bacterial culture with his own nasal mucus during a cold. The discovery followed Fleming's typical pattern. While suffering from a head cold, he was examining bacterial cultures when a drop of mucus fell from his nose onto an open Petri dish. Most researchers would have discarded the contaminated culture and started over. Fleming decided to incubate the dish and observe what happened. Within hours, the bacteria around the mucus drop began dying. But lysozyme had significant limitations. It could only destroy certain types of bacteria and was not effective against the most dangerous infectious organisms. Fleming continued searching for more powerful antimicrobial substances. His laboratory habits remained as casual as ever, much to the continued frustration of his more methodical colleagues. September 3, 1928, began like any other day in Fleming's laboratory on the second floor of St. Mary's Hospital. Fleming was studying Staphylococcus bacteria, the microorganisms responsible for many surgical infections, pneumonia cases, and skin diseases. He had prepared numerous culture plates containing nutrient agar seeded with Staphylococcus colonies. On this particular morning, Fleming was cleaning up accumulations of old culture plates before departing for a family vacation. Most of the dishes contained the expected bacterial growth. Some showed contamination from airborne microorganisms that had settled on the nutrient medium. Fleming routinely discarded contaminated cultures, but something about one particular plate caught his attention. The dish contained Staphylococcus colonies as expected, but also showed a large blue-green mold growing in one section. This type of contamination was common in Fleming's laboratory. What was unusual was the clear zone around the mold where Staphylococcus bacteria had completely disappeared. The mold appeared to have killed the bacteria in its immediate vicinity. Fleming's first instinct was to discard the contaminated plate like dozens of others. Laboratory protocol demanded destroying contaminated cultures to prevent spread of unwanted microorganisms, but his observational instincts made him pause. The clear zone around the mold suggested that the contaminant was actively destroying bacteria rather than simply competing with them for nutrients. Instead of discarding the plate, Fleming set it aside for further examination. This decision violated standard laboratory practice and drew criticism from colleagues who saw it as another example of Fleming's sloppy technique. But Fleming's scientific curiosity overcame his concern for laboratory protocol. He wanted to understand what was killing the Staphylococcus bacteria. Fleming carefully transferred samples of the mold to fresh culture medium and began systematic study of its properties. He identified the contaminant as belonging to the genus Penicillium, a common blue-green mold found throughout the environment. Penicillium species were well known as food spoilage organisms that grew on bread, fruit, and other organic materials exposed to air. Initial experiments confirmed Fleming's observation. When grown in the presence of various bacterial species, the mold produced a substance that killed or inhibited many types of disease-causing bacteria. The effect was particularly strong against Staphylococcus, Streptococcus, and several other dangerous pathogens that caused pneumonia, blood poisoning, and surgical infections. Fleming discovered that the mold's antibacterial activity varied significantly depending on growth conditions. Temperature, humidity, nutrient availability, and pH levels all affected the production of the active compound. The substance appeared to be secreted into the culture medium where it could kill bacteria at considerable distances from the mold itself. Further testing revealed that the antibacterial compound was water-soluble and remained stable for several days at room temperature. When filtered from mold cultures, the clear liquid retained its bacteria-killing properties even when diluted substantially. This suggested that the active ingredient was potent enough to be therapeutically useful if it could be concentrated and purified. Fleming also observed that the substance seemed to be relatively non-toxic to human cells in preliminary tests. When he applied crude filtrates to cuts on his own hands, they caused no apparent irritation or damage. This was crucial because many chemical disinfectants that could kill bacteria were too caustic for use in living tissue. Fleming named the active substance penicillin after the Penicillium mold that produced it. He published his findings in the British Journal of Experimental Pathology in May 1929. The paper described penicillin's properties and suggested its potential medical applications. The scientific community's response was lukewarm at best. Fleming's reputation for sloppy laboratory technique made many colleagues skeptical of his claims. The paper appeared in a specialized journal with limited readership. Few researchers bothered to replicate Fleming's experiments or investigate penicillin's potential further. More significantly, Fleming himself lacked the biochemical expertise to purify penicillin or develop it into a practical medicine. He was a bacteriologist, not a chemist. Isolating the active compound from mold cultures, determining its chemical structure, and developing stable preparations required specialized knowledge that Fleming did not possess. Fleming made several attempts to interest pharmaceutical companies in penicillin development. He contacted British drug manufacturers and described penicillin's potential for treating bacterial infections. The companies showed little enthusiasm for investing in what appeared to be an unproven compound discovered by accident in a notoriously messy laboratory. By 1935, Fleming had largely abandoned penicillin research. He moved on to other projects and rarely mentioned his discovery to colleagues. The mold that had contaminated his laboratory sat preserved in his culture collection, scientifically interesting but medically irrelevant. Fleming's accidental discovery seemed destined to remain a minor footnote in bacteriological literature, but greater developments and greater urgency lay immediately ahead. In 1939, as war clouds gathered over Europe, two Oxford University biochemists would encounter Fleming's obscure research paper and recognize possibilities that had escaped the scientific community for an entire decade. Howard Walter Florey was born September 24, 1898, in Adelaide, Australia. He grew up in a prosperous urban family where education and achievement were highly valued. Florey excelled academically from an early age, showing particular aptitude for chemistry and mathematics. He won a Rhodes Scholarship to study at Oxford University, where he completed his medical degree and developed expertise in pathology and biochemistry. Ernst Boris Chain was born June 19, 1906, in Berlin, Germany. The son of a successful industrial chemist, Chain grew up surrounded by scientific equipment and chemical laboratories. He showed exceptional talent for biochemistry and pursued advanced studies in organic chemistry before the rise of Nazi Germany forced his emigration to England in 1933. Chain possessed the specialized knowledge that Fleming lacked. He understood complex chemical structures, purification techniques, and the methods needed to isolate active compounds from biological sources. His expertise in biochemistry perfectly complemented Florey's medical background and research management skills. In 1938, Florey and Chain began collaborating at Oxford University's Sir William Dunn School of Pathology. During their literature review, Chain encountered Fleming's 1929 paper describing penicillin's antibacterial properties. The paper had been largely ignored for nearly a decade, but Chain recognized its potential significance. Chain convinced Florey that penicillin deserved serious investigation. They obtained cultures of Fleming's original Penicillium strain and began the difficult process of producing and purifying penicillin in useful quantities. The work proved extraordinarily challenging. Penicillin was chemically unstable and present in very low concentrations in mold cultures. Working 18-hour days throughout 1939 and 1940, Chain and his team gradually solved the purification problems. They developed methods for concentrating penicillin from culture filtrates and removing impurities without damaging the active compound. By early 1940, they had produced small quantities of relatively pure penicillin. The first animal tests exceeded their most optimistic expectations. Mice injected with lethal doses of Streptococcus bacteria survived when treated with penicillin. The drug showed no apparent toxicity even at high doses. Most remarkably, penicillin was effective against bacteria that were resistant to all other available treatments. On May 25, 1940, Florey and Chain conducted their landmark experiment. They infected 8 mice with lethal doses of Streptococcus bacteria. 4 mice received penicillin treatment, while 4 received no medication. All 4 untreated mice died within 16 hours. All 4 mice treated with penicillin survived and recovered completely. The results were so dramatic that Florey initially suspected experimental error. They repeated the experiment multiple times with identical outcomes. Penicillin was not simply slowing bacterial growth or providing modest improvement. It was completely curing infections that were otherwise uniformly fatal. The first human trial began in February 1941. Police Constable Albert Alexander had scratched his eye on a rose thorn while gardening. The minor injury had become severely infected, spreading to his entire face and threatening his life. Traditional treatments had failed, and Alexander was dying from what should have been a trivial scratch. Dr. Charles Fletcher administered the Oxford team's entire supply of purified penicillin to Alexander over 5 days. The results were miraculous. Alexander's fever broke, the infection cleared, and he appeared to be recovering completely. For the first time in human history, a doctor had cured a life-threatening bacterial infection using a specific antimicrobial drug. But the supply of penicillin was exhausted, and Alexander's infection returned. Without additional drug to complete the treatment, he died a month later. The case demonstrated both penicillin's extraordinary potential and the critical need for larger quantities of the drug. Partial treatment was not enough. Despite Alexander's death, the trial had proven that penicillin worked in humans exactly as it worked in laboratory mice. 5 additional patients were treated with larger supplies of penicillin that the Oxford team had managed to produce. All 5 patients recovered completely from infections that would have been fatal without treatment. Word of penicillin's success spread quickly through British medical circles. Military doctors were particularly interested given the enormous number of infection-related casualties in active combat zones. But production remained the critical bottleneck. Britain's chemical industry was devoted to producing explosives, fuel, and other war materials. Florey made a crucial decision that would determine penicillin's future. In July 1941, he traveled to the United States to seek American assistance with large-scale production. The timing proved perfect. Although the United States had not yet entered World War II, American military planners understood that large-scale conflict was likely. American pharmaceutical companies attacked the production problems with industrial efficiency. Pfizer, Merck, and Abbott Laboratories committed massive resources to solving manufacturing challenges. They developed new fermentation techniques using deep tank methods instead of surface cultures. These industrial fermenters could produce thousands of times more penicillin than Oxford's laboratory flasks. Engineers designed automated systems for harvesting and purifying penicillin from fermentation broths. They solved problems that had seemed insurmountable to academic researchers working with limited equipment. Temperature control, contamination prevention, and yield optimization required innovations in chemical engineering that had never been attempted at such scale. The United States government coordinated the effort through the War Production Board, treating penicillin development as strategically important as radar or atomic research. Companies shared technical information despite normal competitive secrecy. Patents were pooled to accelerate development. Resources were allocated without regard to normal profit considerations. By 1943, American factories were producing penicillin in quantities that would have seemed impossible just 2 years earlier. Production increased from grams per month to kilograms per week to tons per month. The manufacturing scale-up represented one of the most impressive technical achievements of World War II, rivaling the Manhattan Project in complexity and strategic importance. Quality control presented enormous challenges. Each batch required testing to ensure potency and purity. Standards had to be established for a drug that had never been mass-produced. The Food and Drug Administration developed new approval processes to balance safety with wartime urgency. Military medical officers worked directly with manufacturers to ensure battlefield supplies met therapeutic requirements. Lieutenant Robert Chen, lying wounded on Normandy Beach, carried one of the first battlefield doses of mass-produced penicillin. The yellowish powder in his medical kit represented the culmination of Fleming's accidental discovery, Chen's chemical expertise, Florey's systematic research, and American industrial capability. Within hours of his injection, Chen's infection began clearing and his fever dropped. Throughout 1944 and 1945, penicillin transformed battlefield medicine. Infections that had killed soldiers throughout history became minor inconveniences treatable with a few injections. Pneumonia, gas gangrene, and sepsis ceased to be death sentences. Surgeons could perform complex operations knowing that post-operative infections were preventable. The impact extended far beyond military medicine. Civilian hospitals gained access to penicillin for treating everything from strep throat to life-threatening pneumonia. Childbirth complications caused by infection dropped dramatically. Tuberculosis patients who had faced years of suffering found their conditions curable with antibiotic therapy. By 1945, penicillin was saving an estimated 7,000 lives per month in American military hospitals alone. British and Commonwealth forces reported similar results. German military medical reports captured after the war revealed desperate attempts to develop similar drugs as their casualty rates climbed. The strategic impact was profound. American and British forces could commit to more aggressive operations, knowing that wounded soldiers had much better survival chances. Complex amphibious assaults like D-Day became feasible partly because medical planners could count on treating infected casualties successfully. German forces, lacking access to penicillin, suffered disproportionately from infection-related casualties. Hitler's military leaders complained that minor wounds were removing soldiers from combat for weeks or months. Some German units reported losing more men to infection than to enemy action. Alexander Fleming, whose discovery had been ignored for over a decade, suddenly found himself celebrated as one of the war's heroes. In 1945, he shared the Nobel Prize in Physiology or Medicine with Howard Florey and Ernst Boris Chain. The three men had transformed an accidental laboratory contamination into humanity's most powerful weapon against bacterial disease. Fleming's acceptance speech at the Nobel ceremony reflected on the role of chance in scientific discovery. He acknowledged that his sloppy laboratory practices, criticized by colleagues for years, had created the conditions that made penicillin's discovery possible. Had he maintained perfect sterile technique, the contaminated culture would never have existed. But Fleming also emphasized that chance favors the prepared mind. His years of studying bacterial behavior had trained him to notice unusual phenomena in contaminated cultures. His experience with lysozyme had taught him that natural antimicrobial substances were worth investigating. His observational skills, developed during childhood in rural Scotland, had enabled him to recognize significance in what others dismissed as laboratory error. The post-war development of additional antibiotics followed the pattern established by penicillin research. Scientists systematically investigated other microorganisms that might produce antimicrobial compounds. Streptomycin, discovered in 1943, proved effective against tuberculosis. Chloramphenicol, isolated in 1947, could treat typhoid fever and other diseases resistant to penicillin. Within 2 decades of Fleming's discovery, bacterial infections that had terrorized humanity for millennia became treatable conditions. Pneumonia, once called the captain of the men of death, became a minor illness curable with oral antibiotics. Tuberculosis sanatoriums closed as patients recovered through drug therapy. Surgical procedures became routine operations with minimal infection risk. The impact on human lifespan was dramatic. Average life expectancy in developed countries increased by more than 10 years between 1940 and 1960. Most of this improvement resulted from reducing infection-related mortality. Children who would have died from strep throat or pneumonia survived to adulthood. Fleming continued research at St. Mary's Hospital until his retirement, though he never again made discoveries comparable to penicillin. He became a popular speaker and author, traveling internationally to describe antibiotic development and advocate for scientific research funding. In his later writings, Fleming expressed concern about antibiotic resistance, warning that overuse might eventually reduce their effectiveness. Fleming died March 11, 1955, at age 73 from a heart attack at his London home. His funeral at St. Paul's Cathedral was attended by thousands of people whose lives had been saved by penicillin. Representatives from dozens of countries honored the Scottish bacteriologist whose laboratory accident had changed medical history. The tactical legacy extends beyond any single drug or discovery. Fleming's experience demonstrated that scientific breakthroughs often emerge from unexpected sources. The most important discoveries may come from accidents, contamination, or apparent failures rather than systematic research programs. Maintaining scientific curiosity about unusual observations can reveal phenomena that transform entire fields. Modern antibiotic development continues to follow principles established during penicillin research. Scientists systematically screen natural products from bacteria, fungi, and other microorganisms searching for antimicrobial compounds. The emergence of antibiotic-resistant bacteria has validated Fleming's early concerns about drug misuse. Fleming's story reminds us that scientific progress often depends on individuals who noticed significance in apparently minor observations. His willingness to investigate a contaminated culture plate, despite criticism from colleagues who considered his laboratory practices substandard, led to discoveries that saved millions of lives. During World War II, when Lieutenant Robert Chen received his life-saving injection on Normandy Beach, he carried the cumulative result of decades of scientific work by researchers on 2 continents. The yellowish powder that cured his infection represented humanity's victory over microscopic enemies that had claimed lives throughout history. Alexander Fleming commanded attention for one accidental discovery that revolutionized medicine and influenced the outcome of global warfare. He transformed laboratory contamination into therapeutic breakthrough through careful observation and scientific curiosity. He earned humanity's highest recognition for work that began with colleagues laughing at his moldy Petri dishes. On March 11, 1955, at age 73, he died knowing that his discovery had changed the fundamental relationship between humanity and bacterial disease. St. Mary's Hospital preserves his laboratory as it appeared on September 3, 1928, when contamination became revelation. The bench where he noticed bacteria-free zones around blue-green mold remains testament to both scientific accident and prepared observation. That's how Fleming's contaminated cultures launched the antibiotic revolution through accidental discovery that validated systematic investigation, transformed battlefield medicine, and established the foundation for modern antimicrobial therapy. The revolution happened through sustained collaboration between academic research and industrial production, changing both medical practice and the strategic balance of global warfare for the remainder of human history.